I'm Professor Heather Wakelee from Stanford University, where I am the Chief of Medical Oncology and Deputy Director of the Stanford Cancer Institute. Approximately a decade ago, we started to see very exciting data with PD-1, PD-L1 checkpoint inhibitors in metastatic lung cancer, where they were leading to shrinkage of tumors and actually improvements in survival compared to traditional chemotherapy. And therefore, it's very logical to bring those drugs into earlier stages of lung cancer where we could theoretically make an even bigger impact. And the idea would be that if we could bring in a checkpoint inhibitor to patients who still had intact tumor, that could elicit a strong immune response, just like we see in metastatic disease. And then, if there was response, surgery could then lead to even further reduction in tumor burden. The initial studies were pilot studies giving just single agent checkpoint inhibitor, particularly with nivolumab was one of the first used. And that actually led to a pretty profound, what we call a pathological response. So major pathological response in lung cancer is less than 10% of viable tumors, and some even receiving a pathological complete response. And so there was a lot of excitement about those high rates of major pathological response. It was 40% in the first studies, have come out closer to 20% as we've had more data. But really this idea that if you could give a checkpoint inhibitor when there was still tumor, you were more likely to set off a strong immune response, which could then have some durable implications after that surgery, where you still have those surveillance immune cells around looking for any tumor cells that might still remain after that surgical resection. The first studies used just single agent checkpoint inhibitors showing response rates initially as high as 40%, and now down to about 20 was sort of what came out. But there was also data showing that if you gave the checkpoint inhibitor with chemotherapy, those responses were even more robust, which mimics what we see in patients with metastatic lung cancer. Therefore, the first pivotal trial was the Checkmate 816 study, which gave patients with early stage lung cancer, stage 1, 2, and 3A. They received up to 3 cycles of chemotherapy plus or minus nivolumab. And that study showed a profound benefit where we're hitting that major pathological response rate again around 20, or pathological complete response rates around 20%, major pathological response rates a bit higher. And patients were able to go to surgery. There's been a lot that's been done looking at how did this impact surgical outcomes. And in general, it didn't have any sort of negative impact. There are some inflammation and other problems that surgeons have talked about, making the surgery perhaps more challenging, and others talk about it being even easier because the tumor has shrunk, and technically it's not so difficult. And the data shows that when you look at multiple outcomes such as duration of surgery and things like that, truly no harm from giving this neoadjuvant immune therapy, and patients overall doing better. So we've seen significant improvements in what's called event-free survival. Event-free survival is our kind of traditionally thought of response rate, disease-free survival, but it also includes any events that prevent a patient from going to surgery. So when we talk about giving these neoadjuvant approaches, we're talking about event-free survival. So here, event-free survival is quite robust, and we now have some data going out to 4 years of follow-up from this study. And again, these patients only had 3 cycles of chemo, plus nivolumab, had surgery, and then no additional treatment beyond that. And with that, the event-free survival at 4 years is almost 50%. It's 49%. Overall survival being reported at 71%, which is higher than what was seen in the control arm. And those results do seem to differ by patients with PD-L1 expression in their tumors and without, with more robust numbers shown for those with PD-L1 expression, less clear benefit without. But really quite striking, and to have this 4-year difference where we're clearly seeing this event-free survival, potentially overall survival difference, has significantly changed what we're able to do from a practice standpoint. So really, really encouraging. We've also had now a number of other studies which are looking not just at pure neoadjuvant, but also looking at adding in additional treatment afterwards and whether that additional component makes a difference. And there's a lot of debate. That's, I think, one of the more controversial questions right now in the early stage lung cancer. I think we've definitively shown now that giving chemotherapy plus an immune checkpoint inhibitor prior to surgery, especially in stage 3, leads to really robust outcomes and benefit. The question is, should we do more with additional treatment? And also, are there patients who maybe should skip that and go straight to surgery, such as those with stage 2? I think one thing that we should always mention is that when we do a neoadjuvant approach, some patients don't make it to surgery. It's consistently about 20%. And so that's another area where we really need to continue to study that. The approval of neoadjuvant or and sometimes perioperative, where you get the neoadjuvant and adjuvant, those regimens have really been approved globally. Of course, not everywhere, but in most parts of the world. And so we're seeing that for patients with early stage resectable lung cancer, especially stage 3 that's considered to be resectable, patients are getting this neoadjuvant approach with chemotherapy plus immune therapy because there's a lot of enthusiasm for these improved outcomes, including what looks to be an overall survival benefit. So this has really become a standard. And when we look to how that's impacted guidelines, of course, there are multiple different guidelines in the world, but when we look at NCCN, what's in there now is that all patients should be evaluated for a preoperative therapy, this neoadjuvant approach. At this time, the approvals are with chemo, with nivolumab, or chemo plus pembrolizumab, with the pembrolizumab regimen including additional adjuvant, but we'll get to that section. Neoadjuvant therapy, though, should not be used to take a patient whose tumor is felt to be not resectable and try to convert that into something that is resectable. I think that's one really important point. We still have a role for definitive chemotherapy and radiation in the unresectable stage 3. And those outcomes, of course, improved with immune therapy also given after that chemotherapy and radiation. So we have to be mindful. It's really important for these patients to have a tumor board discussion with thoracic surgeons, with radiation oncologists, with medical oncologists, and other groups to make a decision up front about, is this patient someone who's really heading toward surgery or not? And if not, trying to make them on that path is really not the best plan for the patients. So that's emphasized in these guidelines. And they also emphasize the importance of testing. We need to know PD-L1 status. That does impact probability of benefit with the immune checkpoint inhibitors. We also need to know whether or not a tumor harbors a driver mutation, because we know that patients with driver mutations, which are known to not respond well in the setting of immune therapy with metastatic disease, especially ALK and EGFR, don't do well with these neoadjuvant approaches with checkpoint inhibitors. And it's really better to know about that driver mutation so they can get other more appropriate treatment, such as targeted treatment with EGFR. We know from ADAURA. With ALK, we know about from Alina using alectinib. So there are other options, and we need to do the testing. And then with the ESMO guidelines, there's still a lot of debate and ongoing, and some approvals in certain parts of Europe, but I think that's going to continue to change over time as these data continue to mature. In addition to the randomized phase 3 trials, there's also been an increasing amount of literature looking at real-world experiences with the neoadjuvant approaches of chemo and checkpoint inhibitors. And they're all supporting this idea that there are pathological complete responses somewhere in that 20% range, major pathological responses. It's harder to talk about those other outcomes without that randomized trial control. But I think these are being widely adopted, and the real-world data supports what was seen in the trials. In addition to the PD-1, PD-L1 checkpoint inhibitors, there's been a lot of excitement about other checkpoint inhibitors such as TIGIT and LAG-3 and some others. The data so far has been a little slow to mature in metastatic disease, so we've left with some questions, but there have been trials bringing some of those drugs in. There's also a few others. There's a drug called oleclumab, one called monalizumab, which have been studied more so in patients with unresectable disease who have had chemotherapy radiation in the COAST trials. We had some updates on those at ASCO 2024. There are also the NeoCo study bringing those drugs in as well as some others. And there's an ongoing larger trial looking at those options, as well as many others. And I think there's also enthusiasm for trying to understand responses with other strategies like circulating tumor DNA, but that's more in the post-surgical setting that becomes more of an option, but a lot of new things to explore. I'm Professor Heather Wakelee from Stanford University, where I am the Chief of Medical Oncology and Deputy Director of the Stanford Cancer Institute. We saw this great benefit giving neoadjuvant chemotherapy plus checkpoint inhibitor. And at the same time those trials were launched, there were studies looking at, can we just give that checkpoint inhibitor after surgery in the adjuvant setting? And the data from the first of those, Empower 010, actually read out around the same time as the Checkmate 816. So we had both the positive neoadjuvant and the positive adjuvant trial coming out almost back to back a few years ago. We've seen 2 randomized phase 3 trials at this time with adjuvant treatment. The Empower 010, which enrolled patients who had completely resected stage 1B, 2, and 3A non-small cell lung cancer. They had to get cisplatin-based chemotherapy, and then they were randomized to get a year of atezolizumab or best supportive care. There's a very similar trial, the Keynote 091 or PEARLS trial, very similar design. The difference being patients did not have to get that chemotherapy, and then they were randomized to get a year of pembrolizumab or placebo. So the other difference, it was a placebo-controlled study. And the results from both were positive. They both showed a disease-free survival benefit, but there are some caveats. And I'll mention in the adjuvant setting, and we're just talking about disease-free survival, different than with those neoadjuvant approaches. In the Empower 010 trial, it had a hierarchical statistical testing plan. The first group were patients who had PD-L1 expression on their tumor stage 2 to 3A. And it's in that subgroup that we've seen the most robust benefit. There was still positive results for the next subgroup, taking out that PD-L1 expression, just stage 2 to 3A, but really the benefit was only in those with the PD-L1 expression. And so for that study, the next step was all comers and then overall survival. But that last step, overall survival, couldn't be formally tested because the drug really just wasn't working in this setting unless there was PD-L1 expression. And so we didn't hit all of those levels. The study with pembrolizumab was a little bit different in that it also showed this nice disease-free survival, very similar to the kind of all comers from the Keynote 091 and Empower 010. Hazard ratios kind of around 0.8 when you look at all comers on the trials. But in the Keynote 091, the PD-L1 levels didn't seem to matter very much, which was a bit confusing because PD-L1 has been a really important biomarker with pembrolizumab across all other trials. And it's also been a really important biomarker in all the other perioperative studies. But that was the data here with these. When we talk about the data that exists, we actually now have 5-year survival results from this Empower 010 trial. And so when we look specifically at that greater than 1% stage 2 to 3A, the disease-free survival is actually more than 30 months difference. So it is statistically significant. And there's an overall survival trend, but again, for the statistical reasons, we can't call that anything definitive. What's particularly noteworthy in this trial and relevant when we think about global approvals is that the most robust benefit was seen in patients with PD-L1 expression of at least 50%. And there, the disease-free survival hazard ratio and the overall survival hazard ratio, 0.47. So really quite a striking difference. And that's where the label is for most of Europe. In the US and parts of Asia, any patient with at least 1% expression of PD-L1 can get that adjuvant atezolizumab. The pembrolizumab approvals are sort of regardless of PD-L1, but there's a lot of question about, are we truly helping those two patients where tumors don't have the PD-L1 expression? It's also important to note that both of these trials did allow patients who had driver mutations. There was some testing that everyone was tested. What we see from that, though, is in patients who do have like ALK translocations, they're not benefiting. Patients with EGFR, it's a little bit confusing because there might be benefit, but now we know that in the adjuvant setting, using a targeted EGFR drug, osimertinib, from which you saw from the ADORA trial, is far more positive. So we do recommend testing, do recommend PD-L1 expression, but to see these positive results long-term from Empower 010, the positive results from Keynote 091, does tell us that giving adjuvant immune checkpoint inhibitors is a viable option. And there are some patients where going to upfront surgery is probably their better choice, or patients who go to surgery and then are found to be upstage to actually have like a stage 3 with minimal disease. So adjuvant checkpoint inhibitor, single agent after chemotherapy is approved and is a good choice. And we have some questions about maybe should we be giving the chemotherapy plus the checkpoint inhibitor together? Are there some other options as well? The positive results from the Keynote 091 with pembrolizumab and Empower 010 with atezolizumab have led to global approvals of these treatment options. In the United States and multiple other countries, especially in Asia, there is approval to give adjuvant atezolizumab for a year for patients whose tumors express PD-L1 at any level and are stage 2 to 3A. In Europe, that approval is only for patients in the EU for high PD-L1 expression of at least 50%, and in some areas excluding patients who have known EGFR mutation or ALK translocation, which is quite reasonable. Now, with pembrolizumab, those approvals are a bit more broad and they don't have that PD-L1 restriction. But as I mentioned, I think that there's some biology questions around that study, given that it's an outlier from other pembrolizumab trials and an outlier from all of the other trials of using checkpoint inhibitors in that early stage setting. When we look at the formal guidelines, as I mentioned, the NCCN guidelines do recommend atezolizumab in patients who fit that greater than 1% PD-L1 expression and do not have a known driver mutation, which would contraindicate use of that checkpoint inhibitor. And when we look at the NCCN guidelines for superior sulcus, there's some modifications around that with chemotherapy and radiation, but that's a pretty rare subset indeed. And the ESMO guidelines take a little longer to get updated, so not as clear recommendations from those at this time. It's most important that every patient with early stage lung cancer is reviewed at a tumor board with multidisciplinary representation before a treatment decision. If a patient does go straight to surgery, we want to know the stage, we want to know the PD-L1 expression of the tumor, and we want to know the driver mutation, as well as any contraindications, risk to the patient themselves from a checkpoint inhibitor, such as autoimmune disease. And based on that criteria, can then make a recommendation for whether or not they might benefit from an adjuvant checkpoint inhibitor. The results with adjuvant atezolizumab and adjuvant pembrolizumab are encouraging, but they still leave room for improvement. And so there is work looking at whether we can add other things to it. And there are also ongoing trials that were very similar. We haven't seen the results yet, looking at other immune checkpoint inhibitors in the adjuvant setting, and some looking at whether we can combine that checkpoint inhibitor with chemotherapy, which is sort of that next logical step. Some of the other things being studied are the TIGIT inhibitor, tiragolumab is in a big adjuvant trial. And there's also a lot of excitement around vaccines, personalized vaccines, with large trials ongoing with that as well. And that's the V940 is one of those particular vaccines. I'm Professor Heather Wakelee from Stanford University, where I am the Chief of Medical Oncology and Deputy Director of the Stanford Cancer Institute. We've talked about the really exciting data with neoadjuvant immune checkpoint inhibitors, where initially just 2 doses of single-agent checkpoint inhibitor led to complete pathological responses, major pathological responses, and then confirmatory data from the CheckMate 816 trial with 3 cycles of chemo plus nivolumab, significantly improving event-free survival in patients with early-stage lung cancer. And we've talked about the adjuvant data with adjuvant atezolizumab, adjuvant pembrolizumab, both showing significant improvements in disease-free survival. So what about combining? And that's that perioperative approach where we're giving both neoadjuvant and adjuvant. And we've now seen data from a number of trials looking at that. The first being the Keynote 671 trial. We've also seen Aegean and Keynote 77T, Checkmate 77T. And so these are all positive trials. They've all shown significant improvements in event-free survival. And the Keynote 671, which was one of the largest to read out, was the first to show a definitive overall survival benefit. And so that's been pretty exciting data where we are now not just showing improvements in those event-free survivals, but also overall survival. And we do expect that the other trials are likely going to hit that overall survival endpoint with more time. These are patients with early stage lung cancer. And so fortunately, it takes a while, which is a good thing for those events to happen where we're starting to see a separation. But in all of the trials, when we look at overall survival curves, we do so that with time, there is continuing separation. One of the things that was particularly exciting at ASCO in 2024 was we had some longer term data from a couple of trials where we can actually now look and see that around that 3-year mark, looking at event-free survival or disease-free survival and overall survival, we're starting to see a plateau, which looks to be a true plateau at that 3-year mark. So when we look at the curves from the Checkmate 816, now with 4-year data, and from Empower 010 now with 5-year data, we do see that at 3 years. And I expect we'll see that with these perioperative trials as well. So let's talk more about the perioperative trials. Again, we've got the pembrolizumab trial with Keynote 671, the Checkmate 77T with nivolumab, and then the Aegean trial with durvalumab. And they were all very similar. They all gave 4 cycles of chemotherapy plus or minus the checkpoint inhibitor, and then patients went to surgery, and then they got up to a year of additional checkpoint inhibitor in that maintenance phase. So very, very similar. And when we look at the results, they're also pretty similar with significant event-free survival benefits, hazard ratios in the 0.58 to 0.68 range at initial presentations, and really, I think, meaningful benefits with all of these. So it's hard to choose between the drugs from that standpoint. They also all showed that there was more benefit in patients who had higher PD-L1 expression. But we also see that even in patients who don't have PD-L1 expression in their tumors, there does seem to be benefit, though the 95% confidence intervals cross 1 in all of these cases. They're definitely shifted in favor of receiving that checkpoint inhibitor. And so that PD-L1 expression becomes a really important factor in trying to figure out, is this a patient who should get a neoadjuvant approach, maybe perioperative? Are these patients who could maybe just go straight to surgery and get a pure adjuvant if they have that highest PD-L1 expression? One of the questions that comes up with these neoadjuvant and perioperative approaches is it worth it? Are we impacting the patient's quality of life? And there was some data at ASCO 2024 presented by Marina Garcino, which demonstrated in the Keynote 671 that there really wasn't a detriment in the health-related quality of life, that even though patients were getting this checkpoint inhibitor, in general, their outcomes were very similar to those who were just getting the chemotherapy component. Of course, we have to be mindful of immune-related adverse events for any patients getting a checkpoint inhibitor, but giving those improvements in disease control and now overall survival, it balanced out. And so that's reassuring. And I think we'd see similar outcomes from the other trials as well. We also had some updates at ASCO 2024 looking at how did patients who had N2 disease, the true this 2 stage 3 patients, and there were some updates from Aegean and from Checkmate 77T, both of them showing that in patients who had the lymph nodes, clear benefit with the addition of the checkpoint inhibitor. There had been some questions around how receiving checkpoint inhibitors could lead to inflammation in lymph nodes, potentially have negative outcomes for surgery. And that was a concern that's been raised off and on. But really, when we look at the data and talking to surgeons who have had a lot of experience operating in patients who've had immune checkpoint inhibitors in that neoadjuvant perioperative phase, even though there is some lymph node inflammation, the surgical outcomes actually look better when patients have had a checkpoint inhibitor in addition to the chemotherapy. And that's because of those robust responses. So having N2 disease, if anything, is a strong indication that if you're going to go with a surgical approach, these patients should get neoadjuvant treatment and should get neoadjuvant chemo plus a checkpoint inhibitor. We've known for decades about the importance of neoadjuvant chemo for N2 disease when you're thinking about surgery. And now multiple trials, very strong data supporting chemo plus a checkpoint inhibitor. And that was again from ASCO, additional data there. Any patient who is found to have an early stage non-small cell lung cancer, except perhaps those who clearly are stage 1A who are going to go straight to surgery, these patients need to be discussed in a multidisciplinary tumor board that's going to include a radiation oncologist, a surgeon, pathologist, medical oncologist, and of course, folks who are able to work with the imaging radiologists to help determine what is really the best step for these patients. Because we have great data for chemotherapy and radiation with additional immune therapy for patients who have that truly unresectable, bulky disease, bulky N2 disease. And then we have these perioperative approaches where giving chemotherapy and immune therapy prior to surgery is really the best option for stage 3 patients going to surgery, for many of the stage 2 patients who are going to go to surgery. But then there are also some where there might be reasons why going to surgery up front can make sense, some of the stage 2 patients. So we need that discussion up front so we have a clear path forward. And then to recognize that we're not going to make a patient whose tumor is unresectable become resectable, but we're also not that likely to have a patient who is currently resectable become unresectable. When we look at all of the trials, there is about a 20% rate of patients who were enrolled on these trials of neoadjuvant or perioperative who didn't make it to surgery. And the reason for that are varied, but we do have to be mindful that we do want to go straight to surgery for some of the patients because of that risk. For stage 3, we really should do neoadjuvant, but for some stage 2, it's something to think about. And so that's an important tumor board discussion. We also need to be reminding ourselves that patients who get a checkpoint inhibitor can get an immune-related adverse event. And there are patients who really aren't going to be able to tolerate those. Patients who have underlying significant autoimmune problems should not get checkpoint inhibitors. Patients who have organ transplants should not get checkpoint inhibitors. There's some of these, but then there are also some nuances, and it's important to talk through it. Some of these immune-related adverse events like hypothyroidism, those are lifelong issues that the patient's going to have to deal with. And so it's weighing those things. And of course, making sure that the surgeons are going to be comfortable taking patients to surgery. More and more surgeons are becoming very comfortable with that, but it is an important factor to be mindful of. As part of a multidisciplinary discussion and making a decision for each patient, one of the key parts of that is not just looking at how does the tumor look on imaging and aspects of the patient, but we also need to know a lot more about the tumor. We've talked about the importance of knowing that PD-L1 level because that can guide probability of benefit, but we also really need to understand the molecular underpinnings of the disease. And that is critically important because if we have a patient whose tumor is harboring an EGFR mutation or an ALK translocation, and they get started on neoadjuvant chemotherapy plus an immune checkpoint inhibitor, it's not that likely to benefit them. We know that from patients with metastatic disease, but it also means that immune checkpoint inhibitor is in their system and remains in their system for months, which can increase toxicity at a time when you might want to instead start a targeted agent. We know that for patients who have EGFR mutant lung cancer or ALK positive lung cancer, we now have very robust data that giving adjuvant TKIs is really the best approach for them. And so if in that neoadjuvant setting they've had a checkpoint inhibitor, they go to surgery, and then it's time for them to start their TKI, we might have to postpone that because of that increased toxicity risk that can happen with the risk of pneumonitis, with osimertinib given in the setting of having a checkpoint inhibitor. Hepatic toxicity is a risk with some of the ALK drugs as well. And so it's really, really important that we fully understand a tumor before making that treatment decision. And so, in a minimum, trying to get EGFR and ALK. And I would argue that many of those other drivers that we see at lesser frequencies, but that pretend a worse outcome with a checkpoint inhibitor, such as ROS1 and RET, that if we can understand that, we're really going to be able to make an even more informed decision for a patient. Because checkpoint inhibitors are fantastic for most patients, but they can cause harm to anybody who receives them. And we don't want to give them to patients who are unlikely to benefit, where there especially might be other options, or where we might be increasing toxicity risk with those other options. We've talked about several perioperative trials, the Keynote 671, the Aegean trial, the Checkmate 77T, but we need to be aware that there are multiple other trials looking at this perioperative approach. There were two large trials that were done predominantly in Asia, in China. There is the Rational 315 trial with tislelizumab, and also the NeoTorch trial with toripalimab. And in both of those trials, robust event-free survival benefit was seen. These are both trials that include that neoadjuvant and adjuvant approach, the perioperative. And these trials were showing robust event-free survival benefit, as has been seen with the other trials. These studies are a little different because they enrolled predominantly patients with squamous histology, mostly men, and that was because they excluded patients with a known EGFR mutation. And in China, that excluded most of those with adenocarcinoma and most of the women. So differences, but very robust positive data, and supporting this idea that checkpoint inhibitor plus chemo prior to surgery is a great approach, especially in patients who have higher PD-L1 expression in their tumor, and especially in patients who do not have a driver mutation. And so we do need to remember to check. Many of these trials excluded patients with known driver mutations. So important to know all aspects of the tumor, and all aspects of the patient's history before making that definitive decision. In addition to knowing about all of our PD-1, PD-L1 checkpoint inhibitors, there are a lot of other agents that are under investigation, other checkpoint inhibitors like relatlimab, newer checkpoint inhibitors. So there's a lot of opportunities for research and a lot of questions around how much does that additional adjuvant piece add when someone's had a good neoadjuvant approach already. So a lot of studies trying to ask that question, some using ctDNA, other ways to stratify patients. And so we've got a lot to learn still. It's a really exciting time for patients, for investigators looking at early stage lung cancer, and totally new world now where we can use these immune checkpoint inhibitors for the majority of patients with early stage lung cancer and make meaningful differences.